So I'm Tony Hoffman. I'm a lecturer here at the University of California, Santa Cruz. I have a doctorate in child development from the University of Oregon, and I've been working with children in my entire professional life. The last 10 years I started getting interested in children in international settings, particularly children that were living in difficult circumstances, and I came to an observation that perhaps the worst and most significant crisis affecting children throughout the world, in any part of the world, is the HIV crisis. I've come to specialize and focus my interests on working with this crisis. When we look at disasters, when we look at international catastrophes, when we look at terrible events that happen to kids, one of the last things that's talked about is HIV. And yet, in the last 50 years, the most serious disaster, catastrophe that has happened to children has been the HIV epidemic. It's happening now, it's worsening, and it's likely to not get better until the earliest estimated time of 2020 or possibly 25. About 250,000 children in Africa are being infected with HIV each year. The great majority of effect that HIV is having on children is that it's killing their parents. HIV in Africa in particular affects young people between the ages of 15 and 35, which is the childbearing age, and hence many young people who are having children are getting the illness, which drives that family unit into poverty, into chronic illness, and ultimately it robs the children of their parents. So children's poverty, which follows the parent's death, involves them ending up living in kinship care with relatives, usually their grandparents, and these grandparents or aunts and uncles are completely overburdened in many parts of southern and now eastern Africa by the numbers of children that they're having to care for. So poverty, exposure to other illness, declining abilities of the children to go to school, the children's own illness are all actually amplifying and growing within African communities. Response of many well-meaning and well-intended groups to the HIV crisis, particularly in sub-Saharan Africa and even more particularly in East and Southern Africa, has been to try to build children's centers and children's orphanages in areas that are particularly affected by the HIV crisis. Christian groups in particular, but not by themselves, have been very concerned and genuinely trying to help the situation by building orphanages that are located in communities, but nonetheless are institutions where children are raised in large group settings. In general, however, this response has been very problematic. One myth is that is that orphanages end up taking care of orphans. And in sub-Saharan Africa, the reality has actually been is that orphanages are taking care of abandoned children whose parents abandoned children or children whose parents have given them up to orphanage care because they believe the child will live a better life in the orphanage, or because they lack the means to care for the child. So we have children in many parts of Africa and other HIV-affected parts of the world who actually have relatives outside the orphanage who could be caring for them. And furthermore, even when we look at all the orphanages that have been established in these parts of the world, they have been inadequate to the task. It costs more per child in many of these parts of the world to raise the child in the orphanage than to have the child raised by family members. and often these children are not cared for by a person who develops the attachment and the cultural and community-based cultural norms and caring systems that these children need to grow up within their societies or return to their societies. So in general, most of the large children's advocacy groups, UNICEF and social welfare experts have come to the conclusion that the orphanage movement is insufficient to the task and is in many cases inappropriate to address the needs of what have come to be called HIV-affected children or orphaned and vulnerable children, or OVC. So what do we have as an alternative here? I mentioned a little bit of a clue here, is that the cost of raising these children in orphanages actually exceeds what it would cost to have the children raised in some kind of by relatives or by the parents themselves. And so more and more people are turning to community-based models of support where these impoverished HIV-affected families actually get cash transfers or some kinds of financial support to provide for their children in their time of illness and their time of greatest need. And these cash transfer schemes and social support programs are flowering and growing throughout South Africa, Namibia, Botswana, Tanzania, and a number of other countries in Africa with good results. Not universally good results, but much better results than we have from the orphanage situation. Historically, there was this huge struggle with the HIV and AIDS community in Europe and the U.S. For the large pharmaceutical companies and the health institutions of these countries to provide easy access to antiretroviral medication for HIV and other medications that help prolong the lives of people with HIV and that help with prophylactics of transmission of HIV. That struggle took an embarrassingly long amount of time, and many people died because of the resistance of governments to really address the issue. But in the 1990s, we did get to a point in time where antiretroviral medication for HIV and other prophylactic medications became cheap and affordable in Europe, Russia, even China, certainly across Northern America and many parts of Latin America. So the argument was made by many international organizations that we can do the same for Africa. We can actually make our pharmaceuticals available to African communities in a cheap and affordable way. This effort was tried with the famous PEPFAR program under the Bush administration to address the AIDS crisis in Africa. And it was only marginally successful for reasons that many people were surprised by. But when we look at the cultural context of this, it makes perfect sense. Many people in Africa are unwilling to be tested for HIV. For a wide variety of reasons, the State Department, the presidential attempts on the PEPFAR program, the World Health Organization, and a large number of other public health and health agencies' efforts to provide medications for HIV-affected communities in Africa had at best marginal results. I won't go into what all these reasons were, but they involve corruption, they involve cultural fears, cultural discomfort with the use of medication, and also some real difficulties with the provision of these medications that would have been ineffective for normal protocols of HIV treatment. The most important aspect of these protocols is that these medications be taken regularly and that any person receiving them has a regular supply of them. So that Western approach of medications alone has at best been marginal, and there's been a long a long time and a long period of soul searching among public health officials about what to do in the absence of a purely medical approach. In the long run, after this period of soul searching and really looking at what African communities in particular need, a community-based approach was arrived upon simply because that's how African communities were dealing and have been dealing with the HIV crisis naturally. Whether they are getting assistance or not, communities have come around this issue and have had to deal with it, in many cases, entirely on their own. When we look at the level of support for any one HIV-affected family in Africa, about 90% of its support comes from community, whether the community has an HIV program or not. Another very small percentage comes from national sources, and international sources are also a very small percentage of it. Why does this occur? Because African communities have traditionally always worked around community. When African communities have been affected by malaria or by violence or by measles or the smallpox epidemics that have gone through African communities, there's been a natural system of care that evolves when families are affected by disease and by disaster. There was recognition that sub-Saharan African communities across the continent have a universal approach to what community means to them, and the word that best describes that is the word Ubuntu, that I am or we are all what we are because of our community. And the HIV/AIDS program started working with communities to address the HIV specific problems that communities addressed. Were they childcare? Were they helping sick family members? Were they providing more food stability? Were they were communities in need of transportation or better schooling to help people overcome the poverty that was induced by the HIV crisis? A wide variety of community-based impacts were certainly created and have been created by the HIV crisis, and increasingly the international and national communities have started recognizing that communities need to make their own decisions about what they need to do to best affect have an impact on the HIV affected families in their communities themselves. So the community-based approach is much more of a public health approach. It's also more of a social welfare approach, acknowledging that many people affected by HIV will never get treatment in these communities. We have to admit to ourselves that about 90% of all people in Africa who have HIV will never get any significant treatment for it, and they will live shortened lives because of this. And the community-based approach says that with this heightened level of mortality, the communities can still survive and even come to thrive if the effects of that increased mortality can be adjusted or adapted to in some way. So the approach generally follows the idea that communities are consulted and solutions are sought out that are valuable to the community to help them prosper in the midst of this epidemic. Africa has become poorer because of the HIV crisis. Across the continent, even into northern Africa and the Arabic-speaking countries, the general welfare of the average community in Africa has declined since the 90s, and economic disparity has increased in most African nations, in part because of the HIV crisis. When it affects children in particular, we have not only a higher rate of child poverty, meaning children living in families below the defined poverty lines of different nations, but we're also looking at a higher number of children who are malnourished, who are growing up without proper care from parents, and who are growing up not going to school. So literacy has actually declined in many sub-Saharan African nations, as has the ability of children to enter a reliable and stable workforce. With the urbanization of Africa, another aspect of child poverty affected by HIV has been the creation of populations of street children and children moving to the cities. This is very notable in many parts of southern Africa, where the rural HIV crisis has resulted in children traveling to cities and living on their own there. So unlike the United States, where we look at homeless people mainly being male adults who have mental illness or drug and substance abuse problems, if you go to just about any major city in southern Africa right now, the homeless street population is predominantly adolescent boys and girls. Many of them, by the way, do not look like your stereotypic homeless person. They're well dressed. Many of them are working in social service. Many of them, quote, sleep and live in churchyards or in community areas, and are very upstanding and devoted citizens. But nonetheless, they're homeless. They are living on the streets, and they are exposed to high risk and all the dangers of the street life in the rapidly urbanizing Africa.
Thank you.